Welcome back, everyone. We're jumping right into part 2 of our 20-part Dental Coding and CDT Mastery course. Now, if you were with us for part 1, you'll remember we spent some time building a really rock-solid foundation on core tooth anatomy. We looked at the basic structures that make up a single tooth. Well, today, we're going to zoom out just a bit to look at the oral cavity as a whole. Because let's face it, as medical coders, dental billers, or CPC and CDT aspirants, your ability to accurately visualize the mouth, that's exactly what stands between a clean claim and a super frustrating denial. In this explainer, we're going to totally master dividing the oral cavity into anterior versus posterior teeth, and we'll decode those anatomical directional references you absolutely need for flawless surface coding. Let's get right to it. Okay, let's dive into this outline. Today we're covering our anterior teeth breakdown, followed by the posterior teeth breakdown. Then we'll map out directional references, look at the practical coding impact, and wrap up with a summary and next steps. Starting off with Section 1, our anterior teeth breakdown, focusing on the front of the mouth anatomy. So when we talk about anterior teeth in dentistry and coding, we're literally talking about the teeth located right at the front of the mouth. Clinically speaking, these are the teeth you see immediately when a patient smiles. Their primary mechanical function is to cut and shear food, kind of like a pair of scissors. But obviously, they also carry massive aesthetic significance. And in the coding world, you're going to find that many CDT codes, especially for restorations like composites, are highly specific to this exact anterior region. Now, there are 3 specific types of teeth that fall into this anterior category. First up, the central incisors. Those are the 2 front teeth right in the very middle, top and bottom. Next to those, you have the lateral incisors. And finally, flanking those are the canines, which you'll actually often see referred to in clinical notes as cuspids. So whenever you're reviewing dental documentation, if you see central incisors, lateral incisors, or cuspids, your brain needs to immediately flag them as anterior. This is going to totally anchor your CDT code selection. Moving right along to Section 2, our posterior teeth breakdown, focusing on the back of the mouth anatomy. The posterior teeth are defined simply as the teeth located at the back of the mouth. While those anterior teeth we just talked about are the delicate cutters, your posterior teeth, well, they're the workhorses. They carry the heavy structural load of chewing and grinding up food. And because of this intense physical demand, the clinical treatments, and therefore the billing codes and the materials used, often differ completely from what's done at the front of the mouth. There are 2 main types of teeth in this posterior section. First, you've got the premolars, also known as bicuspids. These sit just behind the canines. Further back, you have the molars, the really large grinding teeth at the very back of the dental arch. If you're preparing for your CPC or CDT exams, making a rock-solid mental link between premolars and molars and the posterior classification is an absolute must for accurate code grouping. Now, what's really interesting about this slide is how the physical function of these teeth actually dictates our coding terminology. The anterior teeth up front, they don't have a flat top. They have a sharp, cutting edge. In coding, we call this the incisal edge. The posterior teeth, on the other hand, have a broad, flat chewing surface designed for grinding. We call this the occlusal surface. You literally cannot use an occlusal code on a front tooth, and you can't use an incisal code on a back tooth. Function totally dictates terminology here. All right, on to Section 3, directional references, where we're mapping the dental arch. Listen, everything in dental spatial mapping starts with the midline. Picture an imaginary vertical line dropping right down the center of the patient's face, dividing the dental arch perfectly into equal left and right halves. This midline passes directly between those central incisors we talked about a minute ago. This imaginary line is basically your anchor point for the directional flashcards we're about to run through. Ready? First up is mesial, which is abbreviated as M. The mesial surface of any tooth is the side that physically points toward or is closest to that center midline anchor. If you trace the dental arch from the back molars toward the front teeth, you're moving in a mesial direction. Simple enough, right? Now, the direct opposite of mesial is distal, abbreviated as D. The distal surface is the side of the tooth facing away from the midline, pointing toward the back of the mouth. So mesial is toward the center, distal is away from the center. Building this clear binary relationship in your head is seriously the easiest way to memorize this for your exams. Next is the facial surface, marked as F. This is the surface of the tooth that faces outward. But here's where we need to be super precise. For the anterior front teeth, the outward-facing surface rests against the lips, so it's specifically called the labial surface. For the posterior back teeth, the outward-facing surface rests against the cheeks, so it's called the buccal surface. But don't worry, both labial and buccal fall right under the broader umbrella term of the facial surface. Finally, completing our directional map, we have the lingual surface, abbreviated as L. This is the inward-facing surface of the tooth, literally the side that's nearest to the tongue. Whether you're dealing with a front incisor or a back molar, the inside surface is always the lingual surface. Let's pivot to Section 4, Practical Coding Impact, taking this from anatomy straight to billing. So you might be wondering, why does this distinction between anterior and posterior actually matter? Why can't a tooth just be a tooth? Well, it matters because clinical documentation drives code validation. For instance, if a dentist does a resin-based composite restoration, CDT rules provide entirely separate code families depending on whether the tooth is anterior or posterior. If you mismatch the tooth number to the wrong regional code, bam, that claim will be denied instantly by the payer, no way around it. So the crucial point here is understanding exactly how these surface abbreviations map out. Notice the layout comparing our anterior surfaces versus our posterior surfaces. Check out the similarities first. Both have mesial, or M, lingual, or L, distal, or D, and gingival, or G, which just refers to the gum line. But look really closely at the differences. The anterior column uses F for facial, and, crucially, I for incisal. The posterior column uses B for buccal and O for occlusal. Memorizing these specific letter groupings, MFILD for front teeth versus MBOLD for back teeth, is absolutely vital for passing your coding audits. Okay, pay attention here, because this is a massive coding nuance that trips up even experienced billers all the time. When you see G for gingival listed alongside another surface in the provider's notes, like buccal gingival, BG, or distal gingival, DG, coding guidelines strictly dictate that this combination is billed as a single surface. It is not counted as two distinct surfaces for restorative billing. Actually, let's add one more. FB, meaning facial buccal, is also considered just one single surface. Why? Because facial and buccal describe the exact same outward-facing side of the tooth. Knowing these multi-letter single-surface rules is a real game changer and will absolutely save you from overcoding and annoying claim denials. And that brings us to Section 5. Our summary and next steps, with a quick recap and a Part 3 teaser. To quickly recap today's explainer, we established the physical distinction between those anterior cutting teeth and the posterior grinding teeth. We mapped the dental arch using the midline to really understand mesial versus distal and inward versus outward surfaces. But most importantly, we connected this spatial knowledge directly to claim accuracy, identifying exactly why an I for incisal belongs up front, while an O for occlusal stays in the back. And you know what? That perfectly sets the stage for our next session. In Part 3, we're going to dive super deep into mastering tooth surfaces and those complex multi-surface combination rules that govern CDT restorations. You will not want to miss it. But before we go, I want you to ask yourself, how many claims have you seen denied or delayed simply because an I was accidentally swapped for an O? Mastery of these basics is literally the secret to a flawless revenue cycle. If you found this explainer helpful, please hit that like button, share it with your colleagues, subscribe to the channel, and follow the playlist so you don't miss a single part of this masterclass. Until next time, keep learning, keep coding, and decode healthcare with Harshal.